In terms of like basic overview of autism, we're looking at children with skill deficits or impairments in 3 major areas. So that's going to be communication, social interactions, and some type of repetitive or stereotypies, rigidity in thinking. And so these are specific to kids with autism, but also individuals with developmental delays typically have a deficit or impairment in one of these areas also. And then the only difference we would be looking at is children with autism don't necessarily have to have an intellectual disability, but usually I would say when you're talking about children with developmental delays, that's typically present. But they're usually going to have some type of, do I just push sideways? Some type of deficit in one of these areas too. Okay. So when we're looking at these 3 skill deficits, the social interactions, communication, and the restricted or repetitive behaviors, what do you guys think would be the most contributing factor to engaging in problem behaviors or having crisis often?
Lack of communication.
Right. So when you have individuals who haven't acquired a functional type of communication or have a severe language delay, those are going to be individuals who are, I would say, you're most likely to have problem behaviors, or when in crisis is going to be the most difficult to resolve, the most difficult to respond to. That makes sense, I assume. Okay, so when we're talking about problem behaviors, we're talking specifically about behaviors obviously that have the potential to cause harm to the individual or to other people. So we're looking at physical aggression, self-injurious behaviors, and then other high-risk behaviors like severe property destruction, running from adult supervision, climbing on things, stuff like that. So when I say problem behaviors throughout, I'm referring specifically to behaviors that are dangerous to themselves or others. And obviously, I'm sure you guys have seen they can come in a different form. So I think it's important when we're talking about this, before we talk about how we're responding to them in crisis, to talk about why those behaviors might be occurring, because if we don't really have a good understanding of why they're occurring or how they've been shaped up, the response to them is not going to be as effective. And it's more important, I think, that we try to concentrate our efforts in the kind of preventative type of way. Obviously, you're going to be in situations where the behavior is already occurring and you're going to have to respond, but if we can, and then once we get them to a point, getting those things in place so that the crisis doesn't immediately happen again. So talking about why, I think we'll spend a little bit of time on that because it's pretty important in terms of the response later. So when we have these problem behaviors, we're typically dealing with 2 different types of behaviors. One type is going to be behaviors that have been learned through a history of reinforcement. They've been shaped up through their environment. And the other type is going to be, sometimes you're going to come in contact with individuals who are responding to some type of internal stimuli or physiological issue going on. Those ones are a little bit harder to respond to. So we're going to kind of concentrate on the ones that are learned through history of reinforcement. Those are more common anyways. So that's where we're going to look at. Okay, so, alright, so we're talking about behaviors that are learned through a history of reinforcement. So basically what this means is that these behaviors are functioning for that child in some way. So I think probably everyone understands that the intention isn't usually to hurt somebody or to hurt themselves, but they have learned these behaviors because they've been effective for them in some way. So they either result in a preferable outcome for the child, or they provide a way for them to effectively manipulate their environment when they don't have alternative ways to do that. So we're going to talk a little bit about the 5 functions of behavior. This is pretty behavior analytic in nature. Have you guys ever worked with behavior analysts before?
I do behavior therapy for autism home support.
Okay. Oh, for autism home support? Oh, so you know.
Yes.
About behavior analysts. Okay, I'm sorry. Okay. So we'll talk about the 5 main functions. Are you familiar with this? Have you learned about this before? You probably have. Okay. Okay, so we'll go over it briefly. I think it's really important, especially when you're looking at preventative strategies and how to respond. So there's 5 major functions: escape avoidance, attention, access to items, automatic, and pain attenuation. We're typically going to be dealing with the first 3. So I'll explain a little bit about each, but the main point is that these variables are things that if they're provided contingent upon the behavior, so during the behavior or immediately after, they're likely to make that behavior continue to happen or happen shortly after in the future. So this is talking about how this functions for that child. So if it's an escape avoidance behavior, that child has learned that in the past when they engage in that behavior, it's in a very effective way for them to avoid or escape some already present aversive stimulus or the presentation of something. The biggest thing about this one, I think, is that a lot of times you're going to be getting these behaviors because they're trying to, if they have a history of them functioning for escape, when they're in an environment they don't prefer to be in, like a hospital, or then you're going to be getting a high rate of these behaviors because they functioned for them in the past to get out of a situation like that. So that's going to be a very difficult thing to deal with. I think it's one of our hardest things when they come in and the whole function of the behavior is to try to get out, and there's really nothing that's going to resolve that. So attention is the second one. Again, in the past when the child has engaged in those behaviors, it has functioned to gain them attention of some kind. So this could be any type of attention. It could be talking to them. A lot of kids find that it gains them access to hugging, even things like verbal reprimands or something that people would typically think of as, negative attention. Doesn't really matter if it results in attention in some kind. And then access to items, activities, environments is pretty explanatory as well. It's resulted in gaining access to something that after they've engaged in the behavior, they gained access to something preferable. Automatic behaviors are ones that just engaging in the behavior increases the likelihood that they're going to occur. So this is going to be more of your sensory or stimulation behavior. So to talk about like not a behavior that's not dangerous, it would be like hand flapping. So just doing it feels good or is preferable, so they're more likely to continue to do it. You don't get a whole lot of behaviors that are crisis behaviors that are automatic, unless they're things like self-injurious behavior, but usually those are going to be occurring anyways and not specific to crisis situations, so those are less likely to see in a crisis. And then pain attenuation is actually one that you may see. So the behavior functions to relieve some type of pain. So a lot of kids, if they have a headache and head banging, then temporarily relieves that pressure or something. It would be a behavior that you would see during that. Those ones are also really difficult because really, unless you can relieve the pain, resolving or getting those behaviors to stop occurring is going to be pretty difficult. So the top three are usually what we're dealing with because they're very easily and very commonly shaped up through their history of reinforcement. Okay, so when we're talking about the functions of behavior, we obviously have to look at the three-term contingency. I'm sure you guys are familiar with this too. So this is your antecedent behavior consequence. So if you guys look at this three-term contingency, just kind of read through it. After you read through it, what do you guys think? What did this child learn basically in this three-term contingency?
Well, if in the last one he learns that, or he or she learns that if he or she wants something to say, do enough, they'll get what they want.
Right. So the other thing to think about in this is that there's a behavior that happened that wasn't really that dangerous, that wasn't effective for them. So the reaching and the whining, not really that dangerous of a behavior, but didn't result in a preferable outcome. So then the other behavior happens and that behavior does get access to the thing that they wanted. So when you think about this, the next time, so this is this child's history, and then you respond to this child, or you come in contact with this child, and there's something that he wants or needs that he doesn't have, what do you think the most likely behavior that's first going to happen? He's going to go straight to the one that last got him the preferable outcome. So basically what happened in this situation is that the behaviors that weren't that dangerous did not get reinforced and the ones that were did, and so then he's more likely to go to those the next time this similar situation happens. So just something to think about when you're responding, that this is a very common contingency that's been shaped up in this child. And so again, looking at that function is really important, because if you can kind of think about this and think this might be what's going on, then we can start to think about providing an alternative for that child to engage in. So usually, and then also just something to think about too in this is, so when we think about why children are engaging in problem behaviors, why do you think in this particular situation, or any really, that someone without developmental delays or autism would not get these behaviors shaped up? Like, what is this child missing that typically developing children have?
Language. Oh wait, it just asked for it.
Right, so some alternative behavior. So really another thing to think about is what skill deficit do they have? What are their skill deficits, and how is that preventing them from having access to some alternative behavior? Because if they have access to the alternative behavior, then there's no need to engage in these ones. So trying to think about what that alternative looks like and how we can provide it is going to be really important in a crisis situation. So usually when you have this situation, then you also have lots of time to teach the alternative behavior and lots of time to not reinforce the inappropriate behavior. Obviously in a crisis you're not going to have the ability to do that. So then what are our alternatives? What are we going to do in a crisis if we don't have time to teach the appropriate behavior? So this is where, obviously when we're talking about responding to a crisis, we can't always get preventative strategies in place first, but I think a lot of times you get into a crisis, but then you get a small portion of time in which the behavior is not occurring, and this is where we can put these preventative measures in place. Or you can talk with your parents or whoever you're interacting with about getting these preventative strategies in place so the crisis doesn't occur again. So that's going to be things. In preventative strategies, we're talking about modifying the environment to limit any possible aversive stimuli that could be contributing to engaging in those behaviors. So you're not always going to have access to be able to do some of those things, but if you can, limiting noise, reducing the light, a lot of times just humming noises and very small undertones or things that bother them. Think about the temperature, all those type of things. So a lot of times when we have a child who comes onto the unit and they're engaging in all these behaviors, that's the first thing we do is try to limit anything we think could be something that's potentially aversive to that child. And that includes talking usually as well, because obviously that's another stimuli that probably in this child's history has not been super effective for them. It's either been given as an instruction, or they've been telling, when someone's talking to them, they're trying to get them to do something. So a lot of times just reducing that too can be very helpful to get them to calm down initially. Also making sure all their basic needs are met. So obviously if they haven't eaten in however long, or they haven't had a drink, or they haven't, slept, that's going to be things that can contribute, that you can think about just meeting their basic needs, especially if they can't tell you, I would just like a glass of water. That's going to be important. So then the other side of that is when they are engaging in problem behaviors, providing behavior support. So this is where we're looking at their alternative options. So especially if they don't have any functional communication skills, providing some other alternative for them to communicate their needs and wants is going to be super important. So a lot of times I feel like too, we'll get parents who they have learned to just know their child's needs. And so they know when he's doing this that they're hungry, or they know how to meet their child's needs without them having to tell you. But when the child gets in contact with somebody who doesn't know those things, and they have no alternative option, they have no way to tell you that. And a lot of times, especially in crisis, parents won't think to tell you, oh, he knows how to use pictures, or he can sign for this, because they don't utilize those things with that child because they just know what he needs. So I think having those things available, if you can, pictures, or an iPad, or even someone who knows basic sign, the eat more, things like that can be really helpful. And then also just having some preferred items and things available to provide as an alternative for them to engage in something else other than the behavior is going to be important. Does that all make sense?
Most kids that come in have other communication
It's getting more.
alternative. It's getting
It used to be that no one did.
right.
5 years ago, it was not. Now, as the awareness becomes more, people are more likely to start to engage in picture exchange communication
Are you
systems.
seeing more low tech or more high tech stuff coming in?
I think low tech is still pretty good, but there are some high tech
Mm-hmm.
options that are getting
Right.
better.
Yeah.
And I think as schools become more aware of the diagnosis and the treatment options and the approaches that
I
have been
think
effective.
Part of
we
how
see a lot
I've seen this way, I did speech therapy for like 15 years, is that working in schools and stuff, schools use them a lot, but they don't always go
Yeah.
home.
Yeah.
And so then coming in,
The affordability is getting better, that's improving,
Mhm.
so it's effective.
I think too, like, it's underrepresented if you just go off the parental report of how many children are using communication devices, because like we said, they just, even if they're very effective for them in other places, parents don't utilize them, and so sometimes you'll ask them, do they, how are we supposed to communicate, and they'll say, oh, well, I don't know, I just know, when in reality, that child is fluent with using a picture communication system, they just aren't using it at home, so I think just having it available regardless, we've had so many kids who the parents will say, oh no, he doesn't use pictures.
Right.
And then we present a board and they're like, oh, exchanging pictures left and right.
so would you suggest having like some kind of visual
Yeah.
just on hand?
Mhm. I actually made some for you guys.
Did you?
that can
I was
take.
gonna say, just like basic, like what would you, okay?
I did, yeah, because I know the other thing is, or something that's frustrating, I feel like, is the typical mode that they use, like the picture exchange communication is most kids are under very strict stimulus control of like the board maker.
Yeah. Uh-huh.
And people don't have access to that.
No.
And it's really expensive actually,
Yeah, it
and
is.
hard to make those materials, and so, you can use real item pictures, but you're not gonna have that on you.
Mhm.
The alternative is always just to present the actual objects also and give them the opportunity to, pick from the object, but certainly if they're a child who can look at a bunch of different pictures and discriminate between them and pick, having more options available is better, so yeah, I would always suggest having it available if possible and not taking the parent's word for the fact that they can't communicate using alternative methods, and at least trying to provide the option. Okay, so the thing that makes me nervous about saying this with trying to provide the alternative options is really providing those options when they're engaging in problem behaviors is also something that can be very dangerous to do, because if you are only providing those things in order to calm them down once the behaviors are occurring, you're just shaping up that same contingency we just looked at. And it's really, I think that's the most difficult part, because sometimes providing that thing at the time when they're engaging in that behavior is very effective at immediately stopping the behavior, but it's also very effective at making it that much more likely to occur very soon after and at a much higher intensity. So it's kind of a fine line between trying to keep them safe without providing those things until you can get a little bit of a reduction in the behavior, and then try to provide those things. Obviously, depending on the severity of the behavior, sometimes ethically, even though doing that right away might reinforce that behavior and make it more likely to occur, if it saves that individual from hurting themselves in that moment, it might be worth doing. You just have to think about, now, how am I not going to continue to shape up this contingency with that child?
It seems like you're right, it would be a fine line, because I have a client right now who's 7 years old. He is PDD, and communication's his thing, and I just met him for the first time last week, and his mom and I were talking for the first time meeting him, and when I came in, he was watching like a Spider-Man movie, and she kind of like, well, he really liked Spider-Man, and it helped him calm down. And I was like, okay, it was my first time meeting the kid, and at some point she mentioned her boyfriend, and her boyfriend's name is Jerry, and he started saying, just repeating how old at first, and we eventually found out that he was trying to figure out how old Jerry was. He said how old, his age, and I had no idea. It took us like 5 minutes, but that level of like anger kept increasing, and I kept thinking, it was my first time as a kid. I don't know a lot about kids with like TDD, and I'm thinking, how can be, kind of stuff. You had such simple things like we had pictures or some type of thing for him to utilize. It would have saved us 5-10 minutes, and he luckily didn't get out of control, but he was starting to get there before his mother was like, oh, do you want to know what my boyfriend's age is? And he nodded his head, and she said whatever it was, like 51 or whatever it was. And I was thinking, wow, and that I can totally see why this kid gets frustrated because, you know, whether in the community or school or anywhere, no one, you know, not many people are understanding him, and simple things like, you know, helping him communicate would go a long way.
Yeah, and I think it's really easy for parents to, I mean, once you have worked with that child for a long time and been with them, they just know what he or she needs, and so I don't think they think about when he's in other environments and people don't know that, what is he gonna do, and how, you know, they think I'm always gonna be there, but then a crisis situation happens and they're in a hospital where nobody knows, and they haven't learned any of that way to, you know, that functional communication, and it's really, really difficult. So I think anytime you can encourage parents to, even though they might know what he needs or they can figure it out, really teaching that child to independently do it in different situations with different people, push that as hard as you can with parents, because it can lead to a lot of problems that don't need to be there. Okay, so the goal then is establishing this safe contingency and still keeping that child safe. Again, a very fine line that's really hard to determine sometimes in a crisis what you should be doing. So what we're trying to do, I think, is, well, we kind of already talked about all this, but when they're engaging in the problem behaviors, trying really hard not to reinforce those behaviors is going to be so important. So when problem behaviors are occurring, we can utilize preventative strategies, like the ones we talked about where you're providing options, but trying to limit doing that while they're actually engaging in the behavior is very, very important. Even if you're not giving, even if you can't figure out, like, I have no idea what he wants, I don't know what to do, mom can't tell me any information, he's just engaging in these behaviors. Sometimes too, a lot of people's inclination is just to kind of like talk and say, what do you need, and do a lot of like calming and coddling and hugging, and usually that's not the most effective way to even get them to calm down, but you're also, even if you don't know what it is or you're not giving them something specifically that they want, you're still showing them, like, this behavior gets a response from me. I'm trying to figure out what you need. If I'm attending to you and I'm talking to you and I'm doing this and that with you, then it may be likely that I'm gonna eventually find something that you do want and give it to you. So sometimes just removing all of that attention and showing them, if the behaviors aren't to a point where they're, you know, really, really gonna hurt someone or themselves, just kind of removing eye contact, removing verbal interactions, and just showing them these behaviors that are occurring right now are not gonna be effective for you to get things, and then as soon as you see a slight reduction in them happening, intervening, and then doing that, okay, and trying to provide other options. So it's just
Yeah, which is also important, you know, Pat and you talked about this too, and a lot of the de-escalation exercises, it's counter to that, you know, which, you know, you see someone in crisis and you want to verbally de-escalate them and work with them, and this is taking a step back, and sometimes that can be an effective strategy to reduce some of the behaviors. And you know, I think, Aaron, you should probably, the difference between someone in acute crisis versus somebody who's engaging in non-lethal behaviors. You know, certainly if a kid's got a knife to his neck,
right,
something like that, then you don't want to disengage them. But
yes.
But if they are, you know, doing some mild head banging or other behaviors, tantruming, just taking a step back and moving attention can sometimes be effective.
Yeah. And then I think the other really important part is not missing the opportunity for when you see a slight reduction in the behaviors to then intervene. So a lot of times what happens is when we're in crisis, all this responding is happening and people are trying this and that, and then as soon as they're calm, it's like, oh, okay. And then, you know, we walk away and we disengage with them, and then, you know, again, it's that contingency of I just learned all these people around trying to find me things when I'm doing these behaviors, but as soon as I'm calm, everyone's walking away from me and not, you know, not trying to find things I like. So even if you can shape up, like you have a child who's hitting, and you kind of, you know, move yourself back and move away, and then they sit down and cry, that's perfect opportunity to then be like, great job sitting down even though you're crying, what do you need, you know, things like that. So just finding that slight reduction in the behavior is a perfect time to intervene is really important too. And I think it's just learning, you know, when to intervene. That's like the hardest part.
And temporal proximity is an important concept. I mean, the closer you can get to the behavior that you want to provide a positive is the critical component. Because then they start to attach it, and that's the shape that you're looking for.
And if I can say something to it,
Absolutely.
especially with like grabs and because we have a lot of kids that will grab and not just immediately going full-blown crisis and responding and going into physical holds and saying good hands, and staff just kind of holding and redirecting and kind of saying this is the behavior we want. We want to see good hands. So and being patient. Now, if it starts to become extreme, then that's different. But just saying this is the behavior we want to see. If it's just grabbing, we kind of hold hands and just, it's okay, good hands. And sometimes it's a matter of just counting down and then releasing. And that's really good to work with the staff. And when we do have staff that transfer to different units and they come up to the unit, working with them and saying, we don't go immediately into full-blown crisis mode. It's just working with them and calming down and saying good hands or just whatever it is you want, reinforcing that.
Yeah, that's a really good point, because when we were talking about the alternative behaviors, because you don't have the opportunity to teach them those alternative behaviors, that doesn't mean you can't show them how to do them. So obviously if this child is having these problem behaviors, they're not likely to know how to independently do what the alternative is. So it's nothing that can't be done, or, I mean, there's no problem with physically showing them the behavior that you want and then telling them, great job, even though you're actually doing it for them. It's still reinforcing the behavior when it's happening, as long as that doesn't turn into, as long as it's not an unsafe situation to like make them do it. But just like Tal was saying, if they're hitting and you grab their hand and then you hold their hands down for them and say, great job having nice hands, I mean, they're not really independently having nice hands, but you're still telling them this is the behavior that I want to see. So it will still reinforce that behavior and make it more likely to occur. Okay, so these are just examples of safe contingencies. So it's just examples of, and we can read through them if you want, but it's just examples of what we were just talking about, where you're like shaping up kind of an appropriate response that maybe isn't that appropriate, but it's more towards what you want to get to. So this obviously involves like having something that you know that they like or want, or having some type of motivating item. Obviously, if you don't have anything like that, this isn't going to work, but finding that out first is going to be important if you're going to try to shape something up like this. So I'll just read through the first example. So you talk to Mom and she's like, oh, he really likes goldfish. And you have him and he reaches for him and you say, great job, and hand him one. And then he reaches again and you say, great job asking, can you sit? So what you're trying to do here is get some instructional control and show this child, you reach nicely and I'm going to reinforce that. I'm not going to immediately tell you, you need to do this behavior before you get this. Reaching is a fine behavior to reinforce. Reinforce it and then try to present, oh, now he knows, like, when I do this, I get something I want, so then try to shape it up a little bit at a time. Now
These
sit,
are just examples.
and then he sits for you 5 of them, and then, try to build in that instructional control. That's going to help too in just
So,
not allowing
unsafe
another
example would
crisis
be,
to occur, like
you
once
find
it's
that they like
wrong.
goldfish,
If you
it's
can
sitting
then
on the
build in
counter.
this contingency and
So this would be like in a hospital
setting,
setting,
or like in a room where there's like
something else that they want.
medical stuff, and they go up and try to grab them, but there's all kinds of dangerous things on the counter, so you don't want them going up and
Same
grabbing
thing
stuff.
with
So you say,
the-
okay, wait,
with
and then
next
the child
example.
starts freaking out and hitting, and then you, oh my gosh, okay, and then you give them the goldfish. That's obviously establishing a very unsafe contingency and teaching a very unsafe behavior. And you're gonna see that happen a lot because the giving them that thing immediately usually stops that behavior, and so that actually reinforces that person's behavior. They're way more likely to do that when the child's having problem behaviors. But if you guys can at least think about this and show this, to the people that you're working with, and do this when you're engaging in a child with a crisis, then it's more likely that you're gonna get some instructional control. They're gonna have a safe contingency with you. And especially if parents can see that happen, I think that, you know, just a couple times of when they see like, oh, if I don't have to give it to them right away, but I wait and then shape this up, then it really, I mean, it doesn't take very many times for them to be like, oh my gosh, okay, that works, and so. So I think that's pretty much all I had. Do you guys want to, like talk through any specific examples or give any specific situations that you've been in, or if you have any questions or concerns, or specifically for Dr. Nichols or Pat?
Over the last 5 years, you have come across quite a few different challenges, so.
Yeah.
Yes, that is true.
Would you say for keeping the stimuli, like at home to a minimum, would you say that that's, should it be any stimuli that they react to, or could it be stimuli that they haven't reacted to yet? Like the reason why I mention that is because a lot of families' homes I go into, you know, like the toys are everywhere, like there's a lot of, it's kind of everywhere, and there would be, I guess more ideal to kind of talk the parents up, putting it all in one spot, simply because then if they walk in the room, they don't see 20 different things around, it's just one area.
Yeah,
I mean, I know that food is a better example because like, you know, there's a lot of issues that go on with that, but.
I think when we have parents, when we talk to parents about this, I think if you have a child who does engage in pretty severe problem behaviors, at least having some space in the house that is clear of all that stuff. And I think that's the hardest. I feel like that's what parents always say, like, I don't have any space in my home in which I can safely manage when he's in crisis. Like there's nowhere, there's always something that they can grab or pull over. And so then that limits their ability to then remove themselves because they're always intervening, and he's gonna pull the TV on himself or do something like that. So I think encouraging them to try to find just any space where there aren't stimuli like that or things that can hurt them, so that that's a place that they can go when a crisis happens. We always, go ahead.
Yeah, no, I mean, this is something we come up with a lot of problems with, because, you know, in the unit it's nice because we have a quiet room, and it's a safe place. But the quiet room isn't their bedroom, it's not the classroom, it's not that. And so sometimes we'll see parents who are limited in resources and places to do things, and their safe place and their disciplined place are the same place, which is very confusing to a lot of the kids sometimes. I mean, these kids are very concrete and rigid in the way they think about things. And so that's always a challenge to try and do that. But I think your point is, you know, the less stimulation that they have, the better in terms of being able to be organized in how you deliver that stimulation. And I think that's a challenge to most places, and it's a challenge to most families. Because, I mean, the other part of it is that they're usually not the only kid. It's rare that we see an intact family with one child with autism who's severely disabled. It's usually a family with 4 kids who 3 of them are normally developing and will have toys everywhere and want to play. And you don't want to rearrange their lives for the lives of one kid, and that's a real challenge, a real challenge.
Well, it makes you think about like the unsafe one with like the goldfish. I think a lot of parents that I've worked with are okay with almost having their stuff everywhere because it's like, oh, is this gonna help you? Oh, is that gonna help? Like, and it's such easy access, not realizing that, you know, one, if the kid doesn't want it, it's just getting them more upset because they're not understanding it. And 2, it's also teaching them like, okay, when I'm angry, I can just sit here and start getting nuts, and they'll eventually get me what I want.
Something I always recommend is trying to keep at least some of their motivating items completely in like parental control. So the only way that you access these certain items are through my contingency, whether that be I need you to do this first, or you have to be calm, or you have to emit an appropriate request to get it. Not that most parents are not okay with doing that with all of their child's preferred items. They want them to be able to independently go play with things that they like, and I get that. But I think when there's no items that they can't access freely, then you have no motivation ever for them to do anything because they have free access to everything they want all the time. And I think with food especially, that's so hard because people don't want to lock up their cabinets, and, you know, and again, you're not having to teach them to ask for something every time is so much easier if you just have it and they can just go get it. You know, the response effort it takes to every time they want something, prompting that appropriate request is
Frustrating.
hard. Especially if you're trying to make dinner and your other kids are, you know. So I think having an understanding like that, it's not possible, you can't do that, but at least keeping some specific items put away and only under your control will still give you an opportunity at times to build up some type of contingency of you requesting, you know, this specific thing maybe. Not everything you don't have to ask for, but at least this one. And then you're also teaching the asking in some way, because that's what happens when we have kids who come to the hospital who their kitchen is free access for them all the time. And at the hospital we can't have food on the unit, and so they're forced to request if they want it, or engage in behaviors and hope someone like eventually finds something that they like. And it's a very, very common thing that we run into. So just, I think if you want something to, you know, if you want to find a middle ground with the parents who just, you know, there's no way they're going to put all their stuff up and things, is just having at least a couple really highly preferred items put away that there's a contingency for. And they don't have to work on it all day long or all the time or every time, but maybe just a couple times too. And hopefully the skill will generalize.
Food is a particular trigger for me in terms of, because 9 times out of 10, the reward is a food item. And if we're dealing with really problematic kids, they're on medications that are going to increase metabolic syndrome, which is weight gain. And so not every child with autism ends up getting hospitalized. In fact, the minority do. But when they do, their pattern is usually overweight. Contingencies are highly food oriented, and they're high carbohydrate foods. I mean, we're talking chips, fries, hot
Those
Cheetos,
things are like,
those
Those,
sour things.
yeah.
I mean, those are the candies, they're either sweet or sour candies. So those are the things that it just adds to the problem. So, and that's an extraordinary. And Aaron, I mean, we deal with it and struggle with it on the unit, finding alternative contingencies for rewards. I mean, it's the same thing. It's Doritos. It's
I think you get that, and then you get like the iPad,
Yes, the
Like
electronics.
now. I
And
think you get a lot of that now.
there's a problem that we're starting to see more and more as that communication gets into it, because it's not only the communication device,
You
it's
have to
also
have it
the reward
separate,
device.
because
Yeah.
otherwise you get the kids who just click out of the communication device and
Mhm.
just use it to play.
Or you're seeing a kid in crisis and you want them to communicate to you, but it's also the same physical
Right.
object
That
that is
they
their
reward,
reward.
right.
So, you know,
That's a problem with the iPad now.
That's a
Of using
huge problem.
Trovo or using whatever, because it's more.
and I mean, I'll be honest, and I think Aaron maybe agrees with me, I prefer the PAC system
Mhm.
plus an iPad as a reward, because they are separate,
Mhm.
it's not as expensive,
Mhm.
and it's effective. I mean, the PEC system is effective,
Mhm.
and it's very manualized, and it's interactive. It can't be done completely independently. You need somebody else to engage with you to do it.
Yeah, and it requires those prerequisite skills actually, than
Right.
like all the swiping,
Right.
although kids typically learn that before they learn an exchange
It's all-
nowadays.
But I do agree, I think even the kids that tend to use Protocol or
Yeah.
some of those on there, they might use it at school or they might use it with whatever, but as soon as they go home, they tend to use it a lot
It's
for
good.
games and other things.
We've done a lot of training with parents on doing like the guided access,
Mhm.
just so that you can lock out everything except for their
Except that.
communication,
Mhm.
especially when like problem behaviors are happening. Yeah. But yeah, that's a really difficult situation, I think, is trying to find a place that's not in a restricted environment where you can keep them safe, because there's just so much stimuli around. Yep. Anything else? What do you do at Autism Home Support?
I do, my CTM, I go in and do.
Like the programs?
Uh-huh.
Okay. So this is all super,
Well, it is, and I worked at Camelot for 3 years, so I did speech therapy
Oh,
there,
yeah.
so yeah. Which I know we had lots of clients that came here, so yes.
yeah. Yeah.
I guess the only thing that I would add that Aaron didn't cover is, you know, especially for you guys in the crisis teams, and maybe for you guys in the hospital setting as well, you know, one thing that's always challenging for a physician is that when they get children with autism and adults with autism who are nonverbal and have difficulty communicating, that relationship's difficult. You know, we're trained to say, where does it hurt? What is going on? How does it work? You know, what are your symptoms? And not being able to express that is frustrating for the patient or the kid, but it's also extraordinarily frustrating for the physician. And so when, I know when we see, the red flags for me are new behaviors that are happening. Things like hitting yourself in the head banging, that are brand new. Those are things where I'm gonna say, hey, you gotta send this kid to the hospital. And the common things, they can't describe them commonly. You know, some things we've seen is appendicitis or ear infections, strep throat, headaches. These are things that elicit
Tooth
behaviors.
problems.
Tooth is a huge one. We see dental cavities and caries problematic with tooth pain causing a lot of things. So I know it's frustrating for you guys when they're in crisis and we say, and you call our unit and they say, hey, we got this kid at the home, can we send him right over? And we'll say, you know what, send that kid to the ER for a medical evaluation. Now, 9 times out of 10, unfortunately, the ERs don't do the proper evaluation. They'll do a CBC and a CMP and say, hey, he's medically cleared, adios. But these are things that I think would be really important to start to look at, especially when we see an intensification of behaviors that are fairly new and a kid who's nonverbal or has a poor ability to communicate. Those are things that I think warrant a medical investigation. UTI is another huge one, especially in adolescent females who have been nonverbal, have poor hygiene, and recently started menstrual cycles and going into adolescence. Those are things we see a lot. UTIs, cavities, and ear infections are the things that I think are, you know, our biggest cure rate, actually.
Yeah.
We cure the problematic behavior.
Yeah, or like sinusitis. There's
Sinusitis
like
is another
three of those
big
really,
one.
really bad. It's just, yeah, so asking them to like ruling out all medical concerns, especially with new behaviors, yeah.
And finding a developmental pediatrician or somebody to link them up with, not because I think developmental pediatricians are better, but pediatricians in general, you know, they're used to poking on babies, but once the kid's 8, 9 years old and they're used to an interaction that's verbal and that's not there, developmental pediatricians have a superior ability to elicit symptoms without a verbal interaction. And I think that's critical.
Like, I agree with it, especially when it comes to physical goals, especially when they're experiencing symptoms like that. A lot of the physical goals will last longer.
Yeah.
And so the staff is going to be really, really exhausted. So it's going to be longer and more frequent. And the other thing I was going to say from a safety standpoint, here in the hospital, we do have protective equipment,
Yeah.
you know, for the staff. So we do have.
Aaron's got
Yeah,
it right now.
Yeah.
Take him off.
And so I don't know how many, when you guys go on a home, if parents do have those type of, if they have that equipment.
I haven't seen
Some
one.
scratches and, because I'm not sure, but I do think without the protective equipment